Right now, all participants are on mute. So if you have a question, again, please type it in the chat box, or at the end of all of the presentations, we'll have some time for verbal question and answer. So at that time, you can press *7 to unmute your line. And then following the webinar, we'll send participants a link so you can access the PowerPoint presentations as well as the webinar recording. And like I said, we have a full agenda for today's webinar. So first up, we'll have Dr. Linda Anderson, the Director of the Healthy Aging Program at the Centers for Disease Control and Prevention. Then we'll have a couple presenters from California, Dr. Deborah Cherry with the Alzheimer's Association California Southland, and Susan Howland with the Alzheimer's Association California Southland. Then we will have our colleagues from Maine joining us, Christine Merchant with the Maine Department of Health and Human Services, and Catherine Pierce with Dementia Care Strategies. And then we'll have folks from Georgia joining us, Mary Lou Vergara from the Atlanta Regional Commission, and Gail Alston from Georgia Southwestern State University. And then, like I said, at the end, we'll have a time for discussion and question and answer. So at this time, I'd like to please turn the presentation over to Dr. Linda Anderson.
Thank you very much. And on behalf of CDC, I want to thank you all for joining our call today. And I'm just going to make a few brief remarks to put some things in context for hearing our presenters. So one of the things in 2006, Congress appropriated funds to the Centers for Disease Control and Prevention to begin to address issues around brain health. And in thinking about this was done in recognition of several factors. One, as we all know, is there's an increasing number and proportion of older adults in the U.S., shown by that small graph. And we can think since January of 2011, about 9,000 to 10,000 people in the U.S. turn 65 every day, and they'll continue to do so for the next 19 years. So again, one of the issues around thinking about the importance of looking at physical, mental, and cognitive health. There's also been a recognition of the public's increased concern about memory loss as well as Alzheimer's disease. And then what we're dealing with today and we'll be examining will the need to address caregiver issues and caregiver health. So when we think about the significance of caregiving, just a couple facts to keep in mind is that 85% of baby boomers, those that are born between 1946 and 64, want to age in place. And by that we really mean age either in their own home or stay within their community. And on average, 4.6 years is the average length of time for caregiving in home settings. And for persons living with dementia, that may range from 4 to 20 years. And using data from our behavioral risk factor surveillance system, in 2009 we added a core question. We found that 25% of adults aged 18 or older reported providing care or assistance to a person with long-term illness or disabilities in the past 30 days. And we know from the literature that people willingly provide support, but we also know that caregiving activities put people at increased risk for injury, mental health problems, as well as have implications for their economic security over time. And this shows a map, also using the Behavioral Risk Factor Surveillance System 2009 data. And for the first time, we can really see the variability across states and really within regions of these estimates of the people who report that they provide care or assistance to someone. And so we've developed at CDC a series of roadmaps. The first was published in 2007, and it really focused sort of on a national agenda and actions. And it was scheduled to be updated in 2012. So we started that process and have produced the 2013 Healthy Brain Initiative Roadmap. And this is linked to several exciting national efforts that are going on. First in 2011 is the National Alzheimer's Project Act, and then there is a national plan to address Alzheimer's disease. The first appeared in 2012, and the latest that was just released last month in 2014. Now, the roadmap was developed through a process called concept mapping, which has a six-step process from planning to the interpretation. This was led by a 15-member leadership team, which included the Association of State and Territorial Health Officers. It invited input from more than 280 stakeholders. Half came from states and local communities in thinking about the input in these actions, since that's the focus of this roadmap. And then 35 of those actions really our public health community can focus on over the next 5 years. And this is our conceptual framework, which really takes the core public health functions of assessment, policy development, and assurance, and out of the concept mapping, there are 4 major areas that the 35 actions fall under: monitor and evaluate, educate and empower the nation about cognition, develop policy and mobilize partnerships, and then ensuring a competent workforce. And there are several select actions that relate to caregiving, and there are 4 of those that focus on the monitoring, implementing the behavioral risk factor surveillance cognitive impairment module, as well as a new caregiver module, define the needs of caregivers, including Alzheimer's disease as they relate to employment, conduct a national review of caregiver programs and policies, conduct a national level review on the potential use of technology for delivering best practices and programs for caregivers, and then also one on encouraging public health entities to provide links in those with Alzheimer's disease, but also in terms of caregiving. And in the roadmap, I encourage all of you to visit that, and there will be a link that was provided with the description of this. It also includes, in addition to the actions, a number of features that highlight those current activities that are related to roadmap actions. And here I've listed 3 of them that relate to caregiving. And then also, I just wanted to point out, in 2015, we have a new behavioral risk factor caregiver module. It includes 8 questions if the person indicates they provided care in the past 30 days, and one of those is the case definition of being a care provider. And then it has 2 questions, one if they're a care provider, but if they say no, we ask them a question about if in the future, the next 2 years, they anticipate being a caregiver, which will allow states to be able to understand and plan for the future needs. And this relates to a quote from Mrs. Rosalind Carter, of course, the former First Lady and Chair of the Rosalind Carter Institute on Caregiving, that there are 4 kinds of people in the world: those who've been caregivers, those who are currently are caregivers, those who will be caregivers, and those who will need caregivers. And so with that, I end my presentation, and here's our web links and sites. And I'll turn it over to the next presenter. Thank you.
Great. Thank you so much, Dr. Anderson. Dr. Cherry?
Yes, thank you all. I'm presenting on a project on the development of services for underserved communities who are caring for people with dementia. This is a model that I'm presenting that has been replicated in a number of different communities, mostly along the west coast of the United States. And in 1992, federal legislation caused the beginning of something called the Alzheimer's Disease Grants to States. These grants were originally managed by HRSA, the Health Resources Services Administration, and more currently are managed by ACL, the Administration for Community Living. These are 3-year grants, and the early purpose of these grants was to develop local systems of care for populations that were not being reached through traditional services offered by states and local communities. In California, because the grants demanded significant match, and they still do demand this match, 25% in year 1, 35% in year 2, and 45% in year 3, we elected to develop services for Latinos. We picked that population because we're roughly 17% of our over 60 population, and because there was some infrastructure for working with older adults. And this Dementia Care Network model is very much about a collaboration between various organizations that work with older adults to better serve mostly ethnically diverse communities, but also it could be a rural community, an underserved population that doesn't have enough care and support for caregivers and for people with dementia. This is not a top-down model. It is very much about bottom-up implementation. So the guiding philosophy of a dementia care network is to empower the community and give them ownership to build capacity both in the community agencies and in the state, as well as its more Anglo or English-speaking partners, so that together we learn about the culture or the community that we want to serve, and we become more culturally competent. It's also a philosophy that says that if it doesn't work one way, try it a different way. So flexibility is very, very important to the model. To develop a service delivery network for Latinos, our project started with gaps and needs assessment, then put in place personnel to conduct community outreach, networking, awareness, and coordinate existing services. It then went into capacity building activities, training of community professionals, and expanding our programs. The first step in creating a dementia care network is convening your network, and we look to community members with interest and expertise in serving the elderly, and organizations from adult daycare centers to churches that are involved with the elderly in that underserved community. And these entities often lack knowledge of dementia, but have a real interest in service. The structure of our dementia care network looks like this slide. The funding comes through the state agencies. In California, the state has always partnered with the local Alzheimer's Association chapters. The chapters of the Alzheimer's Association have provided grants, training, and technical assistance to partner agencies who are part of that network. And the partner agencies deliver a range, ultimately over 3 years, deliver a range of services from adult day services to care management. But particular partner agencies deliver support groups and care management, and they do so with a key personnel enhancement called a care advocate. The care advocates are placed through the grant funding at 2 community organizations that serve the elderly. Or if there is less funding, it could be 1 community agency that serves the elderly. This bicultural, bilingual person learns to conduct community outreach and caregiver education. They become a trained care manager, often getting this training through the Alzheimer's Association, or a mentor who is from that ethnic community and knowledgeable about care management, and also a support group leader. So they become trained as a local care manager, a local support group leader. They work with families who they've identified through their outreach and community education, and ultimately by year 3 they become experts and become trainers of other staff persons as well, helping to build community capacity. When the network first comes together, they start by conducting, this network of agencies and community leaders conducts a needs and an assets assessment. And they look at characteristics of this community. What are their attitudes toward the government, toward the Alzheimer's Association, toward the agencies we hope will provide services? What are the strengths and weaknesses of the community we want to serve? And in our early Latino work, we had a community that was low in income, had no health insurance, low literacy level, and so forth. So we identified together some of our challenges, but we also identified some of our community's assets. And again, in the Latino community, we found newspapers, radio programs, churches and politicians, and many others who are willing to help us in our development of services. We also put up on a wall frequently a continuum of care showing what is available in this ethnic community and what is not for the family caregivers. And it goes from community awareness, is anyone doing public speaking on the radio, going out to churches? Is anyone educating the caregivers? Do they have adult day centers? To end-of-life care. And in the process of identifying what the community has, what the community doesn't have, and how the community views Alzheimer's disease and caregiving and each other's agencies, a level of trust is developed between the partners that makes it easier and easier for them to work together to develop services. This bullseye comes from HRSA, and it is a reflection of the work done through the first 3 years of the project nationwide. And what we found was we had to conduct over 600,000 contacts with individuals from these underserved communities through outreach and education in order to bring a relatively small number of them in to direct services. It's about 7,000 who came for direct services. And this is a real learning for all of us. Education and outreach is critical if you want to bring people in. They have to start to trust you. Over a 7-year period, or rather a 5-year period, El Portal, the first dementia care network, created a range of services, most of which are still in existence today. Support groups, created a diagnostic center where people could get a diagnosis if they were Spanish-speaking, legal clinics, adult day care centers, and so forth, as you can see on the slide. The initial community response to the project reflected disbelief that this was even an issue in their community. People were not aware of dementia. There was a myth that if you created services for Latinos, and now the same myth exists for many API communities, people won't come because they take care of their own. But the truth was, if you created culturally competent services and delivered them in places people were comfortable going, and delivered them with people who were bicultural and bilingual and knew about dementia care, they would come. And so initial community responses were learned about, and our care advocates, our community-based providers, learned how to overcome them. Ethnic-sensitive services are in the language of the participant. They accept the norms and beliefs of the community. They are hopefully staffed by people who are bilingual, bicultural, and they have to be comprehensive. In our case, we thought we would provide elder law, and we learned that immigration law was something that was also needed. We thought we would connect people with health care, but we didn't realize we would need translators to do so. So this is where some of our flexibility and our comprehensiveness was important. Many times we tried to provide support groups when people were concerned more about their food and their housing. And so we had to create services that were relevant to clients' needs and their way of life, and that were accessible to them. People would go into a particular community, might not seek services across a bridge less than a mile away in another community. You had to know about the community and their willingness to where they'd reach services. There were many challenges to creating this dementia care network. Communication, many people in that community seemed to think that Alzheimer's was a Jewish condition, definitely not a condition for Latinos, and there's been a lot of change in that viewpoint. Small partner agencies needed help with grant writing. They didn't know how to get resources in order to build services and maintain services. They were not well connected to our system of area agencies on aging. There are challenges in terms of policy perspectives. I know our Agency for Community Living over the years, which used to be the Administration on Aging, switched its focus from serving primarily the underserved to doing systems-level changes in states. And so hard to necessarily keep doing this with that funding. And there was also challenges in terms of doing evaluation, when especially working with a lower literacy population. In summary, these dementia care networks, they are scaffoldings. They are there and funded for 3, sometimes 5 years, but then the funding goes away, and you want to leave enough capacity in the community so that there's ownership of the services, there's a dedication to serving people with dementia and their families, and the community agencies will seek support to keep those services going. This model, the Dementia Care Network, has been replicated in other Latino communities in Seattle and San Diego and the northern part of California and Arizona many, many years ago. It's also been replicated in the African American community and amongst a variety of Japanese communities, Asian communities, Japanese, Chinese, Korean, Vietnamese, and Filipino communities have each had dementia care networks developed for them. If you have additional interest, there is a replication manual available on the website that appears in this final slide. Thank you.
Thank you so much, Dr. Cherry. And I know folks may have lots of questions and interest in that presentation, so please feel free to ask any questions through the chat box. And then when all of the presenters have finished, at the end we'll have some time for verbal question and answer. But for now, we'll be moving on to discuss the main Savvy Caregiver program with Christine Merchant and Catherine Pierce.
Christine, did you want to start?
Christine, you may have to press *7 to unmute your line. We can't hear you.
Am I on mute now?
Yeah.
You're good.
Oh, okay, great. So I'm going to just start, say hello, welcome you to Maine's presentation, and then hand it to Catherine. One thing I want to acknowledge that is not in the slides is that we also funded our Savvy Caregiver program through 2 back-to-back ACL grants, each which ran for 3 years. The one we're currently finishing up ran over 1 year, carryover. And the first one had to do with just basic Savvy Caregiver, and the second one has to do primarily with the Savvy 2 or Savvy Advanced course, though it continues the regular Savvy as well. And Catherine will be referencing both. And that now we are, our funding is completing. Our Savvy classes throughout the state are being integrated through the family caregiver programs at all the AAA. All the AAA. So that's just a quick little from where we came and where we're headed with this program, which I don't think is mentioned explicitly in the slide. So, and I've been with this program for the last final 2 years of it. Catherine's been with it since the beginning, since 2009. So thought she would be really great to kind of summarize some of the more detailed aspects of this program, which we have all fallen in love with quite a bit. Okay, Catherine?
Sure. So just kind of at a glance, the Savvy Caregiver program is a 12-hour evidence-based psychoeducational program. The audience that we chose to target were families and friends caring for a person with dementia in the community, not people who are in a facility such as a nursing home. It is delivered in 2-hour sessions over the course of 6 weeks, and our particular focus was rural caregivers. It means a very rural state. And so that pretty much comprises the entire state, except for our couple of major cities. We did offer the program statewide, and we partnered with the main area agencies on aging, the AAAs that Christine referenced earlier, the Alzheimer's Association, and in the last year of the grant, Cary Hospital, which is in Maine's northernmost and probably most rural county. And those organizations had staff that they trained to offer the program. They assisted with recruitment, and in many cases they also provided us with a room for the meetings to take place in. The Savvy one was the original program that we started, and this really has several key concepts. It focuses on helping caregivers understand dementia and how it impacts a person's ability to function, spend a lot of time trying to work on caregiver stress and getting caregivers to take care of themselves. We go over the stages of dementia based on the Allen scale, and I should say this program was done initially by Dr. Ken Hepburn at Emory University, and so this is his program that we just took and pretty much delivered here in Maine, except for the Savvy 2, which I'll talk about in a minute. The Savvy 1 also talks about managing and accommodating behaviors, and it uses the nursing process model to illustrate how to handle behaviors that families oftentimes are so very challenged dealing with. We talk about how to tailor tasks and activities to the stage of dementia that the person is at, and there's a great video of 4 ladies making ham and cheese sandwiches and folding towels, each lady at a different stage of the illness, which I think is a terrific tool for really helping caregivers get a sense of where their family member may be in the stage of dementia. There's also a decision-making tool. We talk about family dynamics, and I think one of the key concepts of the program is what we call try it at home. These programs are offered over the course of 6 weeks, and it's done that way specifically so that caregivers can take the concepts they learn in any particular week, take those concepts home, work on them, try them out when they're at home in the course of the week, and then they come back the beginning of the next week, and we do a debriefing, what worked, what didn't work, and then we build on another concept that they then take home the next week, so that by the time they get to the end of 6 weeks, they've had some good opportunities to practice their new skills and get feedback on them. Because the first Savvy 1, was so popular, we had a number of families who asked, for a follow-up meeting. They wanted more after they finished the first 6-week program. They also were coming through the program. Some people, the frequent flyers, we refer to them as, were coming through the program 2 and 3 times in some cases. And so the second grant that we had, we developed what we called Savvy 2, and this was offered to caregivers at a minimum of 5 months after they completed the Savvy 1 program. And many times the person they were caring for had deteriorated further, and the things they focused on learning the first time around, they had needs that had changed by the time they got a few months down the road. Excuse me. And so Savvy 2 had a number of new concepts. It obviously reviewed the key concepts from Savvy 1 that I just discussed. And we talked in more depth about guiding and shaping behavior. Also did a goodly section on how to build your caregiving team, both formal and informal resources, and helping families to learn that they maybe had more resources than they thought that they might have initially, and also how to ask for help. Also talked about practical and emotional challenges. In many cases, their family members were now further on in the disease, approaching end of life, and were facing many more emotional challenges, the continuing debilitation of the person and what that meant to them as caregivers, perhaps even having to face, having someone placed in a long-term care facility, which was very difficult for many families. And we talked about major decisions, and oftentimes those are end-of-life decisions for families that are so difficult, and so we made a point of talking about those as well. We also did, at the very end of the last year, develop a special program for individuals with intellectual and developmental disabilities and dementia, and we did this because obviously there was a growing number of individuals with IDD who are aging, and particularly people with Down syndrome. A very high percentage of those people will develop dementia, and there really wasn't anything out there for their caregivers. And so what we did was we took the Savvy 1 program and just modified the Understanding Dementia segment to include how dementia in individuals with intellectual and developmental disabilities differs from how it presents in the general population. The remainder of the Savvy program was essentially the same. The family caregivers, we discovered in this population, are very difficult to reach. Some of them are not even in the system, and so that was a challenge. And the other thing that we found, and I did the training for this one, was that in many cases we did have some professionals, group home people who took part in the program, as well as case managers. And we saw that they were oftentimes misidentifying possible cases of dementia and attributing them to being just a manifestation of the underlying disability, or, to use an exact quote, oppositional behavior, and not realizing that this might be a situation where the person was in the early stages of dementia, and that was why their functional level was changing. The outcomes, highly successful program, almost 1,500 people in Savvy 1 over the 5-6 years of the grant. We had just under 200 people for Savvy 2 participating, and in each and every case, we saw statistically significant improvement in how caregivers felt about their ability to respond to disruptive behaviors. We saw a reduction in their depressive symptoms and in their negative reactions to behavior, and those outcomes were sustained at 12 months. And in Part 2, again, we saw great success, improved competence and caregiving skills, even as the person for whom they were providing care was moving into the more challenging stages of dementia. Improved confidence in how to respond to disruptive behaviors, reduce symptoms of depression, and improve mood of the caregiver. And 99% of the caregivers reported that they would recommend this program to others. And in fact, word of mouth was one of the primary ways this program spread. We had a lot of challenges around the way. Recruitment, I don't think, was ever easy. People don't perceive themselves as caregivers. We did have facility staff who wanted training, and this program was not designed for facility staff. The 6-week commitment was lengthy. There has been research that shows the program can be effective in a more abbreviated time frame. The rural focus obviously had challenges. There wasn't respite in some areas of the state. Transportation was an issue, given that a lot of these caregivers are older people on their own. And also in some of the rural areas, there was a very strong sense of we take care of our own. Another challenge was holding classes during the day. That eliminated many of the adult children who work from participating. And when we did offer evening classes, did see a great increase in participation in those classes. Literacy level of the PowerPoint slides, I think in some cases or in some areas was a challenge. These slides, there were several slides in particular that are really look like, frankly, that they were developed in an academic setting and took a lot of explaining on the trainer's part to convey to participants what those slides were meant to be. We did have trainers who didn't have a background in dementia. It wasn't required that they have a background in dementia, but obviously you get family members who ask a lot of questions about what do I do when my family member does this, that, or the other thing. Without that background in dementia, that was difficult for them to handle. And also in some instances, I think we had some trainers who didn't have a lot or any group facilitation experience and hadn't done any training before. And so that was a bit of a challenge. Technology needs, it was expensive for many agencies to outfit their staff that they had trained with the equipment that was needed. And maintaining fidelity is always an ongoing challenge. We did have a few instances where information and concepts were inserted into the program that were not part of the evidence base that we were trying to demonstrate, and so we really had to monitor that. If you want to introduce this program in your area, it's a fabulous program. It's helped so many caregivers. I don't think we can say that enough. We would suggest that you offer it at a variety of times and days, evening hours, Saturday morning programs, and encourage families to attend as a unit. We did have some families that would come in with multiple family members, and I think they really got a great deal out of having that big family unit all getting on the same page. I would strongly recommend that trainers have some background in dementia. At least we did create a guide to understanding dementia as a resource for trainers. Independent contractor to monitor fidelity if you're doing it as some sort of a research project. This program could also be offered in alternative delivery methods, such as online, to get the information out there to people in the more rural areas of the state. Initially, we were trying to recruit volunteer trainers, and that was very difficult because of the time requirements on the trainer, and so we wound up using paid agency staff, and I think that probably is the way that most people would need to go. Advertising and how to get the word out was always a challenge. The hospital system that I mentioned earlier in northern Maine did make use of television and radio advertising, and they had great success with that. Also embedding the program into all of the area agency functions, including whenever someone calls the agency initially and they're doing that initial intake, to screen that person as to whether they would be appropriate for the Savvy Caregiver program. Word of mouth was successful. The most unsuccessful method was probably just sending out flyers to churches and communities. Didn't get a lot of response to that. With the exception of the area agencies who would put it in their newsletters. I don't count that as flyers. Partner early with physician practices, hospice, and people who are on waiting lists in nursing homes, and assisted living facilities and major employers would also be a good source of sponsorship for these programs. Anecdotal findings, a number of things I think we found and would probably match up with a lot of the individuals on this call experience working with families. Families feel let down by physicians. They are given the diagnosis, maybe a prescription, and told to come back in 6 months, and just are not given any guidance on where they should be looking for resources or what their next steps should be. Frequently, diagnostic protocols were not being followed by physicians, especially in the most rural areas. Saw a lot of people who were not getting the proper diagnostic workups and just being told they had dementia based on a quick, at most, mini mental status exam in a doctor's office. The behaviors were probably the most common concern of family members and followed closely by family dynamics and family issues and families who were not stepping up to the plate. Male caregivers, in my experience, seem to have a more difficult time with a caregiver role than women do, and I chalk that up to women tending to be more of the nurturers and caregivers just as a role in life. Caregiver interaction was often a major cause of the agitated and combative behaviors that we saw, and so I think this program was extremely successful in teaching caregivers how they interact and respond to their people, to their family members, can really go a long way to diminishing those behaviors that are so difficult for them. Care recipients were at risk. In many cases, family members, their caregivers, were not aware that the person probably should not be left home alone any longer. They weren't safe to be left alone. They shouldn't be driving any longer. I think a lot of caregivers really underestimated the risk that the person they were caring for were at, as well as caregivers themselves who were at risk ran into a lot of situations where there were weapons in the home, and also with the individual who had dementia might have had a history of spousal abuse, and now that their emotional control was being compromised because of the disease process, it was starting to appear again and create issues. And also, no surprise, majority of caregivers didn't have a support system. They had adult children out of state, and they felt guilty asking for assistance, and I think that was an important thing that the program brought to them, was trying to teach them how to ask for that assistance. And I did put up some resources here for more information on the program, the Administration on Aging, the Rosalind Carter Institute, an excerpt from the Caregiver Manual, and you can also see a preview of the first session with Dr. Hepburn on YouTube. And that is Maine.
Very helpful. Thank you so much. And certainly, last but certainly not least, we have folks in Georgia talking about the BRI-Care Consultation intervention, Mary Lou Vergara and Gail Alston. And again, please remember to press *7 to unmute your line.
Can you hear me now?
Yes.
Okay, good. Thank you.
Thank you.
This is Gail Alston. I am the director of the Rosalind Carter Institute Training Center for Excellence. We offer training, certification, and technical assistance for several evidence-based caregiver support programs through our training center, one of which is the BRI-Care Consultation. We provide that training and certification in conjunction with the Benjamin Rose Institute. I want to thank you for the opportunity to share this experience that we had with the Atlanta Regional Commission Area Agency on Aging in implementing the BRI-Care Consultation Evidence-Based Caregiver Support Program in Georgia. It was funded by the aforementioned ADSSP funding source at ACL. We're very fortunate to receive that funding and able to bring this very valuable intervention to the state of Georgia. Next slide. There you go. I wanted to share with you a couple of quotes that I found in this article written by Talley and Cruz, just to emphasize the fact that caregiving has recently been recognized as a public health concern. Not only does the intensity of providing care for someone impact the general well-being of the caregiver, but it also puts a care recipient at a risk of premature placement in a nursing facility. So we do want to start gauging that that impact on public health and addressing it through our public health systems. Next slide. Next slide. Oh, there we go. I'm sorry. I think I had a problem with mine. Go back one. There we go. For several years now, the Rosencarter Institute has been using the public health model in identifying the different levels of caregiver interventions. You'll see we have universal, selective, and indicated levels of interventions. Care Consultation would be considered a universal caregiver support program because even though it is personalized and there is that one-on-one communication between the caregiver and the care consultant, it's usually the average amount of time spent is 18 minutes. It's delivered by phone, and it's not characterized by their more intense intervention such as REACH or NYUCI. So we do consider it a universal caregiver support program. Next slide. So you can see it's telephone-based. It is personalized. We offer coaching and empowerment through BRI-Care consultation. It also offers ongoing support and access to ongoing assistance by the client that is served. It offers simple and practical solutions. It helps the client find services. It helps them understand insurances. It also sustains a long-term relationship with the client, which really helps over that period of time. They come to know and trust their care consultant. Next slide. We chose Care Consultation for our implementation for all the reasons that we have listed here. I wanted to tell you that we really wanted to find something that could be offered to the caregivers that not only be very helpful to them, but also be something affordable, something that would carry a high enough caseload that the agencies could really see, yes, this is going to fill this gap and be something we can afford to provide. We actually started by providing this to caregivers who are on the waiting list in Georgia. Sometimes caregivers would go on the waiting list and never come off. So we saw Care Consultation as a way to give those people something while they were on the waiting list. So we first addressed those on the waiting list, then we started offering it to new people as they called in who were about to be placed on the waiting list. We saw it as something very good for our rural caregivers because it wasn't tied to those home visits that were so costly in travel expenses and time. Next slide. The caregivers is really a little different from so many of our caregiver interventions because you can actually work with the caregiver, you can work with the care receiver, or you can work with both of them. It's also a very good program addressing the concerns of long-distance caregivers, and you can involve secondary caregivers that are providing a little bit of assistance, that primary caregiver. Since it's done by phone, you can involve all of these people very easily to help support that caregiving network that's supporting the primary caregiver. It is good to go with caregivers who are going to be able to take a little bit of information, a little bit of encouragement, and move forward with it. If you find that you're working with caregivers that are at that higher risk of burnout, already experience some depression, you can still support them with BRI-Care consultation, but you're also going to want to bring in more intensive interventions. Next slide. Just as what was mentioned before, we found that it's really pretty critical for our care consultants to have a background of they've either been a caregiver or they've worked with caregivers so they can quickly identify the situation the caregiver is involved in. Because it's delivered by the phone, you need to be able to connect very quickly and very, very well with the caregivers. So having someone who has that deep understanding of caregiver issues is is really one of the most important credentials of the person that you put in that spot. Also, a person can carry higher caseloads if you're able to provide some administrative assistance. Next slide. At this point, I will introduce Mary Lou Vergara, who for about a year now has been providing the on-site program management for our Care Consultant program out of the Atlanta Regional Commission.
Thanks, Gail. It's a pleasure to be here, and I'm excited to talk a little bit about Care Consultation. There are actually three major components. First is the initial assessment with the client or person being served. What's unique about the assessment is that it can be done over a 4-month period. And this really allows the consultant to initially, perhaps on the first call, get right to the issue that is of primary concern to the person calling in, and they're not bound to go through a list of questions in that first call. After each call or during each call, there's an action plan that is developed, and the care consultant and the caller reach a consensus about what they're planning to do next. And that action plan can be sent to the caregiver or care receiver, whoever happens to be the client. And it's a great opportunity to give feedback, and over a period of time, when people see how many actions they've actually completed, it's a great empowerment tool. And then a major component is just ongoing maintenance and support. Care Consultation is supported by an information system which we refer to as the CCIS, but it's a computer-based system where the consultant does all the record keeping, and it contains basic demographic information about the caregiver and the care receiver and health conditions. It gives you the ability to put the action steps in, and there are all sorts of reporting features, which was especially helpful to us. And we also found that the folks at the Benjamin Rose Institute were very sensitive to things that we were learning along the way, and they could help us create new reports that would address our particular needs. Another great feature is that it monitors the fidelity to the program, and I think that's been mentioned in the earlier presentations, that this can be a challenge in an evidence-based program. You want to make sure that you're staying true to the program. And then it also has a resource database within the system, which is also extremely helpful. So the care consultant does not have to go beyond that system to find resources. They have them right there at their fingertips. Georgia, as a state, participated in a demonstration project. It was a 3-year project, and similar to some of the other ones that have been mentioned. And the primary collaborative partners were the Rosalind Carter Institute for Caregiving, the Benjamin Rose Institute on Aging, and then there were 3 area agencies on aging in Georgia. We also had very strong support from our state unit on aging, which I think was critical. They were really with us every step of the way, and they've been extremely helpful. And again, the major funding came from a federal grant, the Alzheimer's Disease Supportive Services Program, which is under the Administration on Community Living. Here you'll see a map of our regions and our area agencies on aging within the state of Georgia. We have 12 AAAs. And we worked with 3 different regions, and they were all a bit different, which was really helpful to get different information and see different possibilities for use of care consultation in different situations. At the Atlanta Regional Commission, which is the Atlanta metropolitan area, we were serving urban counties. Legacy Link, which is north of us in the Gainesville, Georgia area, that was a combination of rural counties, but also we have some resort communities up in that area as well. And then towards the south, in the heart of Georgia, in Baxley, Georgia, we were serving all rural counties. There were 17 rural counties, so we really had quite a mix. Just a few of the basics about this program. Over the 3-year period, we served over 600 families in 40 counties in the state. We found that one care consultant could effectively serve 75 to 125 caregiving families. And our average number within the state was about 85 families. So you can tell if one care consultant could serve 125, that that has been one of the outstanding features of the program. Then the average annual cost of service per family came out to $1.03 per day, or $376 a year. And it was based on our salary here at the Atlanta Regional Commission, which generally is higher than some of the more rural areas of the state. We have some preliminary statistical findings, and these have not been published yet, so we can't give very detailed information, but we do know there was statistical significance in caregivers understanding the dementia diagnosis, managing their daily care tasks, getting respite from the caregiving, understanding legal or financial assistance, getting emotional support, and accessing services. And the caregiver health was improved, and that was self-reported by the caregivers. But as has been mentioned earlier, the caregiver health, or I should say the neglect of the caregiver's health, is a huge issue. And so I think we were encouraged by the fact that caregivers had really seen a dramatic effect on their health and their improvement of their well-being. Some of the lessons that we learned, first of all, that BRI-Care Consultation can be delivered successfully at a AAA. This was the first time that the Benjamin Rose Institute had tried using care consultation in an area agency on aging setting. And so we felt that in the variety of settings that we used, that all of them experienced success, and would certainly use it again and would recommend it. And then caregivers and care receivers had a higher care demands, gained the most benefit from participation. And an important lesson learned was the fact that it's better to have one dedicated care consultant than adding care consultation responsibilities to several other staffing duties. Where we've had projects where maybe a case manager is using more traditional case management with some of their clients, and they're trying to use care consultation with others, it just does not allow the person to have the kind of focus that's needed. And also just to gain the skills, both using the CCIS and developing a style of empowerment. And I can't stress enough how this is really a coaching model. And it's definitely working with people that show some initiative and some ability to take charge of their situation. And we don't see these people as relying on a care consultant for a long term. in our demonstration, we were working with families for a 1-year maximum. And we found that that was good in moving ahead. Some other groups have tried using care consultation over a 6-month period, and they felt that that was also equally effective. So, but it's really an empowerment model, and I don't think it's intended to be used over a long period of time. Technical assistance was provided through teleconferences and refresher training and file monitoring, and this is extremely important. You're really teaching and training all along the way, and it was a very important component. And then other people have talked about outreach and what's an effective way. We really did a lot of outreach in a lot of different areas, but we found that most of our referrals came through our information line right here at the Area Agency on Aging. So embedding the program in an agency that can be a source of referrals is extremely helpful, and I think that's where the Area Agencies on Aging probably have a bit of an edge, because we all have an information component to the work that we do. Finally, and probably most important, is future implications for sustainability. And from the get-go, this was a huge issue for us. And we really, every time an opportunity comes along to do a demonstration, in the back of our mind, we always have the question of, will we be able to sustain this? And with care consultation, we really feel that we're making great strides. First of all, it's actually been integrated into our Georgia State Plan for Aging Services. So this is going to be an option moving forward for all the area agencies on aging. And training is beginning for 4 additional regions in the state. Care consultation, we found, fills a gap in service between the information and assistance component and then a more traditional clinical case management. There is a place between those two where there are individuals that we see that we're giving an enhanced case management, but the information and referral specialists are talking to people on several different occasions and following up with them. And we think that that's a perfect niche for care consultation. Also, another important factor with sustainability is that care consultation can be funded with the existing federal and state dollars that we have for home and community-based caregiver programs. And with funding being cut and having to serve more people, this was very, very important to us. So we're really happy that we can integrate this into our existing program. We also have the good fortune of having the Rosalind Carter Institute for Caregiving being located in Georgia, and they're able to provide ongoing specialized training and technical assistance, and that's been invaluable to us. Also, we think that care consultation can play an important role in care transition programming. We have a very large care transition program going on based on the Eric Coleman model. And we've been working with people being discharged from hospitals for a 30-day period. But the end of that 30-day period, we feel that a lot of these people would make great referrals for care consultation. So that's been very exciting. So that concludes our presentation, and I hope we've still got time for questions. But thanks so much for having us.
Thank you so much again to all of our presenters and for the folks who joined us this afternoon. We had one question come through about the PowerPoints, and again, we will send those, the PowerPoint as well as the recording from today to everybody following today's webinar. And if there are any other questions, I want to be respectful of everybody's time. So it is 3 o'clock, but if you have any questions that have popped up and you would like answered, please don't hesitate to email me, and I can direct you to the appropriate presenter. So please don't hesitate to be in touch, and thank you so much for joining. Have a wonderful afternoon.